Good evening, everyone. I'm Joyce. I'm with Jordan and Dr. Barton, who's our speaker for tonight. Thank you, everyone, for joining us again for colorectal surgery virtual education by fellows for fellows. And I would like to start by introducing our speaker for tonight. Dr. Barton is a colorectal surgeon practicing with Northwest Permanente, based in Portland, Oregon. He is originally from St. Louis, Missouri, and attended Haverford College for his undergraduate studies and went to the University of Chicago for medical school. He completed his general surgery training at Oregon Health and Sciences University and his colon and rectal surgeon training in 2015 at UT Houston. After 6 years at LSU New Orleans, he relocated in 2021 back to Oregon and currently works at Kaiser Permanente. In his free time, he spends time with his wife, 2 daughters, and dog, and loves skiing in the winter and playing disc golf in the summer. And you've already gotten a shout out for the name of your dog, actually, on Surgeon.
Oh,
Somebody really enjoyed the fact that you called him Indy. So,
I mean, technically he's Dr. Henry Jones Jr. on all of his paperwork, but we call him Indiana. So we're working on getting the second dog, and I keep trying to convince my wife to name it Marion Barry so we can call him Indian Marion. I think it would be perfect, but she disagrees. So thank you for the introduction. We like to nerd out in this household. So I was asked to give a brief talk, as brief as I can, which is generally not brief, on small bowel Crohn's disease. I'll start by apologizing for my language because I tend to swear quite a bit. So my apologies for that first. But thank you very much to the council for the opportunity to give this talk and chat a little bit about something that I got quite interested in my time in Louisiana. So I'm going to talk about a whole bunch of stuff here. One of my favorite things about Crohn's is actually the history of Crohn's disease. So we'll talk about the eponym controversy briefly for the disease and the grammatical eponym controversy, because I'm also a grammar nut, as Joyce would tell you, as well as the epidemiology and pathophysiology of the disease briefly. Then we'll talk about radiographic findings that are pertinent for us as colorectal surgeons, as well as sort of the general indications for surgery. Then the meat and potatoes of this is talking about jejunal ileal Crohn's disease and terminal ileitis, sort of the two common distributions that we see. I try and leave Crohn's colitis and anoproctitis out of this because each of those individually is yet another hour-long talk. And I know that because I give hour-long talks about those too at the drop of a hat. This is a picture of me after I got a Crohn's consult when I was a general surgery resident. It's that nice hole in the wall that's shaped a lot like me, because I used to think, wow, surgery is the last resort for Crohn's. That's what I've always been taught. Just throw some steroids at them and run like hell. And so my experience since then has been very different. When I was in general surgery training, I was taught surgery is the last resort. Easy peasy. I know we're not going to operate on these patients. You know, you can't cure the disease, so why are you going to operate? Just throw steroids at them. If that doesn't work, throw more steroids at them. If that doesn't work, you can always do the steroids more times per day instead. And that these are just high maintenance patients. You don't want to touch them, you know, like they're annoying, blah, blah, blah. And these are all the things that when you're running a busy general surgery service, that's what you think. Then my colorectal surgery experience started, and things completely changed for me personally with these patients. I found surgery is not a cure for the disease. That's true, but it's an important therapy for the disease and a component of the therapy when used in conjunction with medical management. Obviously, you can't cure the disease, but you can make it a whole lot better. And Dr. Pang will tell you at the drop of a hat that I do everything in life in order to eat because I love food. And this is a disease that takes away the ability to do that. And so to me, it's astonishing how much we as physicians can ignore such an important component of both normal daily life and social activity and not get to the bare bones of that with patients to help make them a whole lot better, both on a day-to-day basis and socially, in terms of the ability to just talk to people and eat with them and stuff. Also, this is important. This is a terrible disease. It's on your list. You know, diseases you don't want is Crohn's disease. It is invisible. Patients have abdominal pain intermittently for up to, on average, 20% of them will have more than 5 years before they're actually diagnosed with the disease of symptoms. And these lifestyle changes occur subtly with time. So everybody around them just says, what are you complaining about? You're skinny, you're complaining about pain. We have tummy aches too sometimes. And that causes significant psychosocial distress associated with this disease. And so understanding that and connecting with patients about that is an important way to help take care of them. And of course, I learned years ago, steroids are only for flares for Crohn's disease, active inflammatory flares, not for the fibrostenotic disease, which gets me to my grammar nuttiness. Nothing drives me crazier than when residents or fellows type the word flare and type the wrong word flare. FLAIR is a natural aptitude or talent or a smartness of style, whereas FLARE is a burst of sudden intensity, like inflammation in Crohn's disease. So when you talk about a Crohn's flare, you're talking about a flare. Whereas when you're talking about a flare of Crohn's, you're talking about a burst of inflammation. So please spell it right, just to keep my sanity intact. So the history of Crohn's disease is extensive. The original paper describing this disease was actually published in JAMA on October 15th of 1932. And during that year was actually when Crohn, or the year prior, I suppose, was when Crohn approached Berg, the senior surgeon at the institution, and said, I've got these 4 patients with this weird terminal ileitis that has granulomatous findings. I haven't seen that before, and I want to talk with you about it, to which Berg responded, 2 of the junior surgeons here, Ginsberg and Oppenheimer, have 11 patients with that. So Crohn presented, sorry, he had 3 because Crohn's presented a 14 patient case series at the American Medical Association meeting in New Orleans that year, 11 of whom were not his patients. And then he wrote the paper with Ginsberg and Oppenheimer. Now, Berg recused himself from the paper because he had never actually operated on any of the patients. So that meant that per the JAMA guidelines at the time, the authorship was in alphabetical order. And if Berg had not recused himself, it would be called Berg's disease. But Crohn subsequently never actually called it Crohn's disease. He never used the eponym, but he did enjoy the fact that other people did. He called it terminal ileitis, and then eventually when it was identified elsewhere in the small intestine, regional ileitis. Interestingly, prior to that in Scotland, Thomas Dalziel had described every symptom of the disease, including fibrostenosis, granulomatous formation, etc., back in 1906. And even prior to that, Coombe and Saunders had described many of the findings 100 years before. And there's some people who theorize that King Alfred the Great, who, if you've ever watched Vikings or The Last Kingdom, he was heavily featured in both of those television series. He was England's darling, they say, but he had known to have postprandial pain, was gaunt with sort of redness in his cheeks, and people thought that he had what they termed hemorrhoids at the time, but some people theorized that he had anal Crohn's disease, and that may have been a cause for his gauntness. That said, he was also famously exceptional at martial acts, so I'm not sure how many Crohn's patients are good warriors too. This is all postulation. Anyway, Ginsberg, one of the authors of the study, actually did comment back in 1986 about this eponym controversy, which wound up with, at the time in the 1930s, a closed-door meeting where nobody knows exactly what was happening that made Ginsberg and Oppenheimer satisfied with all this. But he said Dalziel actually described the whole gamut of granulomatous disease of the bowel, and so it should be called Dalziel's disease instead, which I've always found interesting. That's the eponym controversy again. I nerd out on these things. So as far as epidemiology, we have seen a rising frequency of Crohn's worldwide in the last 30 years or so. We do find that we're up to about 200 cases per 100,000 adults now, and we do see a north to south gradient, as well as specifically in Northern European and Jewish populations. It's more common than others. And interestingly, if you look at so for the fellows, when you're taking your written board exam, the most important thing to know about the pathobiology of Crohn's disease is going to be NOD2 card 15. That's the button you select when they say which of these genes is most associated with the development of Crohn's, is NOD2 card 15. And it can be either of those genes, which is interesting because in the umbrella of Crohn's being multiple different diseases in a lot of ways, East Asian populations less frequently will have NOD2 card 15 abnormalities despite in their Crohn's population. But it's interesting because you see this north-south gradient, this European commonness, and it's hard to delineate, is it regional, or is it the fact that these are the populations that colonize these areas as well? South Africa, for example, has had significant colonization by Scandinavian populations, and so is it because of that? Hashing that out. We do see the bimodal distribution of the disease, obviously. Crohn's is more commonly associated with the second and third decades of life as diagnosis, but there are large populations that are diagnosed in the 60 to 80-year-old range, as well as everywhere in between. And there are data that suggest that generally, if you're diagnosed later, you have a less aggressive form of the disease. Though with that said, you can have plenty of patients who are diagnosed at 60 and have rip-roaring ileitis. The pathophysiology, obviously, we don't know the cause. I love this chapter of the ASCRS textbook because it has a giant Venn diagram with all of the different single nucleotide polymorphisms associated with Crohn's. And you just read it and you're like, and UC, and you're just like, this basically says that it could be anything, which is probably true. But there are a few key findings there, like that JAK2 has been implicated, or again, non-2 card 15, which is most commonly the one you're going to answer on your exam. We do know that there are immune-associated activities, the autoimmune activity of the bowel and its interaction with your immune system. Environmental factors, we know that there are bacteria in the gut biome-related issues that are associated with the initiation of the disease. And we see that in our mouse model of the disease, where when the mouse is raised in a sterile environment, it will not develop Crohn's, but once it's introduced bacteria, that's actually when the Crohn starts to develop, and they start to develop I would say symptoms, but I've never actually asked a mouse if it doesn't want to eat. So, and then there are certainly genetic abnormalities that are associated with this. But it is always important to note that this is a progressive illness. And as fellows, if you take nothing away from the clinical side of this discussion, take away this picture right here, because this is the graphical image that shows the inflammatory phase and high potential of improvement with medical management. But then over time, the x-axis here shows that by 10, 20 years of disease, you see that patients will more commonly have penetrating or stricturing disease, where there's minimal or low potential for improvement of the symptoms that they may have with medical management. And that's when the likelihood of surgery continues to increase. And if you look at the data, the cumulative surgical risk is almost 50% over the first 5 to 10 years after diagnosis of this disease. Half of these patients will get surgery on their intestines within 5 years of diagnosis. And at this point, we're probably at about 25 to 30% who will have another surgery within 5 to 10 years after that index operation. So we're still, when people say surgery is the last resort, it means we're crappy at our jobs. Really, surgery is just a natural component or natural portion of the therapy of the progression of the illness here. This image is from the Dutch Biobank study, where they actually looked at their entire population of Crohn's disease in the Netherlands. And it was kind of interesting, I thought, and so I applied it here because it shows the general distribution of Crohn's. And they use the Vienna classification system here, but they do show that Crohn's occurs in terminal ileitis only in their population about 46% of the time. So it's a plurality, but not majority of disease. And ileitis, sort of the diffuse proximal ileojejunal disease, occurs in about 25% of patients, which is generally the numbers that we're quoting on a day-to-day basis. Colonic disease is actually more common than that, at about 30%. And then obviously anorectal disease is right where my share screen thing is, so I can't see what it says, but it's about 20% to 25% as well. We're going to skip the extraintestinal manifestations of Crohn's because, man, that's painful. Literally. So we're going to focus in on these two populations, the L1 and L3 disease, during this conversation today. Back to terminology and grammar, because when I break up sections of these talks, I like to add whatever random thought crossed my mind that day when I was making this talk. And in this case, it was like 2018 that I made this originally. So in this case, this is my grammar nut coming out again about diverticulum versus diverticula. The plural of diverticulum is diverticula because that's a Latin neuter term. And if the Texas fellows are here, they would know that Randy Bailey will tell you that you cannot change a dead language. Just like datum is the singular of data, diverticulum is the singular of diverticula, not diverticuli. The gendered nouns such as alumnus and alumna are the ones that get alumnae and alumni, respectively. So. I like talking specifically about the radiography for Crohn's disease because it's one of those things that you guys are going to be looking at frequently. And it can help you, especially because a lot of the time the person reading the radiograph officially is not somebody who does body imaging very often, and so just says the standard stuff, there's an obstruction. consistent with Crohn's, but doesn't get granular about thickness of bowel wall, about inflammation, pericolonic inflammation, perioleal inflammation, etc. Moreover, most of the time you see the scans on these patients, it'll be from the emergency department, and so you won't see evidence of actual Crohn's specific scans. So CT enterography is sort of one of the more common studies that you'll see. And it's important to note this is a thin slice CT scan, so 64 slices. And it's a high volume of negative oral contrast that they give. And you can see in image A right here, the bowels are distended because of the negative oral contrast, as opposed to a positive oral contrast that would obliterate your view of the mucosa in this situation. IV contrast is administered for this one, which is helpful for the degree of inflammation as well as for delineation of blood vessels. Things you look for active inflammation on this are obviously fat stranding around the area, because significant fat stranding can implicate flare as opposed to fibrostenotic and progressive disease, and tell you whether or not a patient is going to be going to benefit from steroid management. Mural thickening, the target sign, which you can see here in image C, where you've got mucosal enhancement followed by thickened wall with dark band, and then some serosal enhancement, can be consistently seen in Crohn's disease as well. Image B is nice because you can again see here the mucosal enhancement that goes with the target sign, as well as the narrowing of the channel. The comb sign is one of my favorites, and this goes along with fibrophatic proliferation, which is the proliferation of fat and fibrosis around the small intestine. The cone sign, which you can see here in C, not as well as I'd like, I should get a better image of this in the future, is the engorgement of the vasa recta as they enter into the small intestine here. And it almost looks like the teeth of a comb. It's best usually viewed in coronal imaging, but it's a good way to you can sort of see it here. See all these teeth entering into the small intestine, which implies that that area is one of the areas of mesenteric involvement of the disease. And then fistula formation is often seen on CT enterography, which you can see in image D here. This is where you've got that usual loop back of the small intestine with fistulization to the ascending colon that you see often. I have several images of later in the talk, but that's one of the ways that patients will often decompress themselves. Now, there are other factors that can suggest that you're going to have the failure of non-operative management in Crohn's patients as well, that you'll frequently see on CT enterography. And the most common one that you guys should know is actually the degree of dilation, because greater than 3 centimeter proximal dilation, when in conjunction with a fibrostenotic stricture, suggests that they will not benefit from non-operative management at that point. Their likelihood of failure is high, and at that point, you should move towards surgery. And in fact, that's coming up in one of my eminent conversations for my group now, because our general surgeon said throw steroids at them, but our gastroenterologist said there's greater than 3 centimeter dilation. So this comes up on a day-to-day basis, and you should be aware of your findings that you will see. MR enterography, depending on your gastroenterologist, you may see a lot of patients with this as well. And MR enterography can be helpful, but if I'm being honest, I don't read MRI as well as I read CT scan. I would imagine that's the case for most of you as well, though you should start getting used to it. Talk with your body image people. They can be very helpful. Again, MR enterography, you administer both oral and IV contrast to obtain this study. And then there are also antiperistaltic agents given because of the duration of acquisition time for this study. It's very good at delineating active inflammation. On T1 imaging, you'll see mucosal enhancement, and on T2, you'll see submucosal edema, which can indicate active inflammation as opposed to fibrostenotic disease. And I'll be honest with you, again, not as good as seeing T2 submucosal enhancement and things like that. So I talk with the radiologists in this situation. But I do see things like DWI imaging suggesting active inflammation. And again, as we go more and more into watch and wait therapy for rectal cancer, these are images that you're going to have to get used to looking at too. So taking the time to talk with your body radiologists about the differences in signal and how to identify them, and then looking at your own MRI is going to be important going forward. And in fact, just the other day, I was showing one of my fellows the last part of this, which is the video jigglegram. I'm pretty sure that's the technical term for it, and it makes me laugh every time I say it. But they can actually do video imaging, serial imaging, to show aperistalsis of a segment of bowel, which implies fibrostenotic disease and chronicity of the disease. because of the loss of peristaltic activity in the region. And oftentimes that'll be, pretty abundantly clear, but it's nice to also see and be able to tell a patient, look, this section of your bowel does not move at all, which is why you are having symptoms here. Benefits of each. Again, you may be ordering some. CT has a fast acquisition time. It's easy to get. Obviously, if you walk through the emergency department, you will have probably gotten 2 CTs by the time you get to the exit. So it's easy. It has less motion artifact because it's got a shorter acquisition time, and you have comparison films very often, especially from, again, the emergency department. And it's far less expensive than MRI, though a CT scan does still have a $3,000 cost associated with it. For us, it's good at distinguishing active inflammation because we've seen enough appendicitis over time that we know what fat stranding looks like around the terminal ileum. And we can read CTs better, which is helpful for comparison imaging and for operative planning for us. And patients tolerate it well. You don't have to give Ativan to every patient who goes into the CT as opposed to the MRI. I don't know how many of you have been afforded the opportunity to get MRIs, but it's not the most pleasant experience sometimes. MRI has the advantage of the lack of radiation. Obviously, we deal with a lot of young patients with Crohn's disease, and so the lack of radiation may be to the benefit of the patient, though long-term risk of actually developing a malignancy associated with radiation exposure is quite low, and they will probably not turn into the Hulk over the course of time because of the CTEs we obtain. It is a dynamic study. Again, the jigglegram can be helpful for patient discussions. And it is quite good at distinguishing active inflammation versus fibrosis in the hands of the right, or the eyes of the right body radiologist. The challenge of identifying fistulization or fistulizing Crohn's disease with MRE is interesting because they will argue, the radiologist will argue it is excellent at identifying fistulas, whereas the surgeons will often argue that it's excellent at overcalling fistula as well, because abutment of the walls of 2 portions of the bowel may not mean that there's actually a mucosa to mucosa fistula present. And so they will often call that fistulization when really it is abutment and the initiation of fistulization. But that's an operative finding that you have to be prepared for at the time. And so it can be helpful for planning purposes if you need to, say, separate the terminal ileum from the sigmoid colon and decide whether or not you're going to throw a couple stitches that you deep down know won't do anything, but that it'll heal just fine. Back to terminology. One of my friends once corrected me, and I've never lived down the shame that there's a correct versus an incorrect pronunciation of the word duodenum. And it's pronounced duodenum because, again, you can't change the dead language. And it comes from the medieval Latin duodenum digitorum, which means 12 finger breadths, which is the approximate length of the duodenum, hence its name. In fact, Herophilus described it as the dodecadactylon, which is ancient Greek, also for 12 fingers. And my colleague once told me, you just have to think of Batman and Robin because they are the dynamic duo, not the dynamic duo. And that will help you pronounce that word correctly. This picture used to also be in the chairman of the chairman's office at my old job, very large and signed by Bob Kane. So, special place in my heart. So that brings us to jejunal ileal Crohn's. We mentioned in the Dutch Biobank study, this accounts for about 20 to 23% of patients who have Crohn's disease. And this is your diffuse segment area. This is the challenging one. This is one that can be difficult to manage because of skip regions and because of difficulty with treatment due to risk of short gut syndrome. It can also be subtle in its symptoms because it's a partial obstruction at multiple levels, so it can produce various levels of cramping versus frank bowel obstruction with emesis associated with it. And because the small intestine at this portion is often endoscopically difficult or inaccessible completely, depending on your advanced endoscopy colleagues, it can present challenges with monitoring as well. This image shows a nice thickened loop of small bowel here and another one right here. And if I remember correctly, this patient who I'm showing the criminal on had multiple areas where it was 2 centimeter segments with 3 centimeter normal intestine to 5 centimeter diameter normal intestine in between. It looked like, it almost looked like haustral markings for the small intestine. It was an interesting experience operating on this one. Indications for surgery for the disease. The 2020 guidelines did not change much from the 2015 guidelines, but did have some excellent points that it makes. So there's a 1C recommendation for active inflammation in specific circumstances. Impending or demonstrated perforation is an important time to operate, especially if it's free perforation with inability to control the sepsis. Failure of non-operative therapy in the setting of active inflammation, which is often in the setting of patients with inflammation with an acute flare who do not have any improvement 48 hours after the initiation of steroid therapy. And obviously toxic enterocolitis. And it's important to always note to the general surgeons, remind them that colitis does not have to be large diameter. Patients can have toxic colitis without megacolon. It's a bit of an old-timey term these days, and so we try not to use that anymore. Stricturing disease is an important cause of indication for surgery because no medicine is going to make the scar go away that is the fibrostenotic portion of that layer. The point is made in the guidelines that endoscopic dilation can be considered as long as it is a short segment stricture, generally 4 centimeters or less in diameter. And again, you need advanced endoscopists available. And there should be direct and good quality communication between you and your endoscopist when they're doing this or when you're doing this. Realistically, stricture endoscopic balloon dilation is probably best for pre-anastomotic strictures after the fact. When I was at AIBD in Orlando years ago, Alessandro Ficara was up there on a panel, and they were talking about endoscopic dilation. One of the guys from Boston or Cleveland, I forget which, was really pushing, we can scope them, we can just dilate them, it saves them an operation. And interestingly, if you look at the Israeli data, that suggests that that's not the case. It just delays their operation. And instead, they go back and get dilated every 3 months or so. Big concern. And, the study on intralesional injection of steroids was stopped early because of bad outcomes. So if anybody's still doing that, just sort of show them that study and remind them of that. But then Alessandro just sort of leaned forward at the microphone and said, if you perforate the patient, you don't get to choose your surgeon that night. And it's an important thing to remind your colleagues of too, because you will be working closely with your gastroenterology colleagues on these patients. So making sure that they are aware that you might not be on call the day that they perforate a patient, and that's going to be a trauma surgeon or a breast surgeon doing that operation instead. Penetrating disease with free perforation or a controlled abscess is generally an indication for surgery. The new guidelines do point out that after percutaneous drainage of an abscess intra-abdominally, you can discuss in a multidisciplinary conference surgical versus medical management. And honestly, it'll probably be both of them anyway. Obviously, it's rare to have severe enough hemorrhage in Crohn's patients to require surgery, but it happens sometimes. And patients who cannot obtain hemodynamic stability deserve an operation. This is the one that the pediatric surgeons often forget, and more importantly, the pediatric gastroenterologists often forget, is that growth retardation in patients who are not done growing is an important indication for surgery. You will often see patients who have been seen by a pediatric gastroenterologist and who have dropped off their growth curves. And interestingly, the data show that after surgery in these situations, whether they're having severe mucosal injury and loss of protein to the toilet, or if it's because of stricturing disease and inability to eat, after surgery, within those 6 months afterwards, they will have a catch-up phase, and that phrase is in quotes, a catch-up phase, where they actually jump back onto their growth curve. My old boss used to say they sprout like weeds immediately afterwards. And it's pretty incredible to see. And you will, over the course of your career, see patients who have had Crohn's since they were 9, 10, 11 years old, and who are noticeably smaller than their family members because there is a delay in diagnosis of the disease very frequently. I got to Oregon and I saw like 3 Crohn's patients with small intestine or colonic cancer. And I was like, I didn't know this still happened. But remember, neoplasia is an indication, obviously, for surgical intervention. And this is especially true. I know I said I wasn't going to talk about Crohn's colitis, but it's especially true in the Crohn's colon stricture. Those have an up to 7% risk of underlying neoplastic process inside the stricture. And so that's a firm indication for surgery according to the guidelines. You don't sit on those or do endoscopic dilation or say, oh, let's just try the next biologic agent or things like that, because the risk of cancer is high. And one of the things I like about the newest guidelines, they do mention that medical non-adherence is an indication for surgery. If you know a patient's not actually going to take their biologic agent, you and your team have to be good stewards of the biologic agents, because you have at this point 8 or 9 agents that have to last the rest of their lives. And if you just throw new biologics at them, you will burn those bridges for them. And by the time they are 50, they will have no more medications available to them except for steroids. And that's not a good place to be. So as far as choices for surgery, again, the guidelines say that resection is preferred when there's no evidence of impending short gut disease. You can consider staged operations depending on certain medications, particularly if they're on high dose steroids. You can always consider staged operation or diversion with a stoma. High-risk patients are obviously malnutrition, class 3 or class 4 wounds. It's very common these patients have an underlying infection. Patients requiring multiple transfusions or urgent surgery. And certainly consideration of diversion or temporizing measures. The new guidelines do mention that even with ileocolic resection, you can consider diverting loop ileostomy. But most of these patients are young and healthy enough that with spit and Scotch tape, they'll do okay. And then bowel conserving therapy should be considered in diffuse disease. And that's one of the important components of the guidelines here. And that's what you see in these diffuse jejunal Crohn's patients, is these patients who have multiple segments, and you have to try and preserve the length of bowel so that the biologic agent will allow for mucosal healing and continued absorption and avoid shortcut. So indications for stricturoplasty, because we're going to talk about those extensively. Again, diffuse involvement with multiple strictures. Strictures in a patient who has undergone a prior major resection. So that's greater than 100 centimeters of small intestine previously resected. And so this does require both that you do a good job documenting when you do your operation, because every time you do an operation on Crohn's patients, you are planning for their next operation too. And that your partners have good documentation. Rapid recurrence of Crohn's. This is an interesting one. If they have severe enough fibrostenotic disease or rapid development of recurrent fibrostenotic disease within 1 year, that's an indication to do stricturoplasty next time through, because they're going to recur fast again. And then strictures in the setting of short gut syndrome or impending short gut syndrome, obviously. And a non-phlegmonymous, that's a good word to say, fibrotic stricture, you can consider that. But in the setting of free perforation, you generally do not want to do stricturoplasty. If there's a big phlegmon there, again, you don't, or if there's fistulization or perforation in that area, you generally don't want to do stricturoplasty in that segment. If there are multiple strictures within a single segment, generally it's preferred to resect. And then if there's a stricture close to a site that you were going to resect anyway, then don't do a stricturoplasty right there, just include it in the resection. And you might say, well, what's considered close proximity? To which I would reply, Potter Stewart, the Associate Justice of the Supreme Court many years ago, said he doesn't know what pornography is, but he knows it when he sees it. This is same. You know it when you see it. If it's too close, it's too close. Don't include it in the staple line, and don't have a distal obstruction right next to a staple line. Intraoperative considerations. Number one, so I have only been in practice for 10 years now, and yet it's been interesting to see during that time the widespread acceptance that minimally invasive surgery should be performed up front whenever you can. And open colectomy is important to know how to do. Open colorectal surgery, open Crohn's cases, these patients with diffuse jejunal disease where you're feeling from the ligament of Treitz, the ligament of Treat, and making sure you get all the strictures is important, but minimally invasive surgery is preferred in this patient population, be it laparoscopic or robotic or hand-assisted or whatever you do these days. The goal is preservation of small bowel, and so a less than 2 centimeter gross margin is fine. And the data show that even with positive microscopic margins, you're fine with that. Just give the medication. So you're looking for the areas where there is not creeping fat, where there is less thickened bowel. This is a great example of creeping fat from my time in Louisiana. It's subtle that there's complete fat wrapping of the mesentery all the way around. It's interesting because there are actually 2 theories of the pathobiology of creeping fat in the Crohn's world. One is that it's the mesenteric fat hypertrophying and wrapping around the small intestine at the level of cirrhosis. But the other is actually you'll sometimes see fat islands on these patients, where the theory is that subserosal fat actually hypertrophies and then grows through eventually. So it probably is a little bit of both, but this also demonstrates right here in this picture that Crohn's is a disease of the mesentery as well as a disease of the bowel, and we'll get to that further as well. We got to it. Yes. The mesentery in the area of the Crohn's disease will be thickened, and that generally corresponds perfectly with the degree of Crohn's in that area. Thicker bowel means thicker mesentery and more inflammation of the mesentery, because this is also a disease of the mesentery. It's common in these areas that you will see energy device failure. I still use LigaSure. I use the, whatever the Da Vinci one is when I'm doing these robotically. And both of them, you burn, it looks great. You see a bunch of edema pour out, and then you watch that little blood vessel just gradually open up and start spurting across your room directly at your camera, and you get sprayed and you can't do shit about it. So in these cases, Dr. Peng will point out as she sits there that I always have a 2O Vicryl or a 2O polysorb available in these situations. And if you're not comfortable laparoscopically sewing or robotically sewing, you should get comfortable with that or be prepared to grasp that and open quickly in those situations. And some people don't, just skip the vessel sealing devices because of this known outcome of mesenteric management. Others will argue that higher ligation avoids this, but the extent of mesenteric resection is actually a very controversial topic in the Crohn's world. There, in what was that, the 2021 ASCARS meeting in Tampa, there were back-to-back talks from Cleveland Clinic and from somebody who was representing Tadakono's data from Japan, saying that high ligation and distal ligation in mesentery respectively reduce the risk of endoscopic recurrence of Crohn's. So that's not helpful. Both of them are reducing the risk, then which one are we supposed to do? And there remains a controversy in the Crohn's world. But knowing that the mesenteric severity corresponds to the degree of bowel wall severity is also helpful if you are doing minimally invasive surgery and cannot feel the areas of Crohn's. You may see short segments, 1 centimeter or less, where there's creeping fat and bowel wall and mesenteric thickening, and the stricture at that site is subtle, but is definitely one that's contributing to the symptoms of these patients. As far as choice of anastomosis, again, the new guidelines say dealer's choice, and the data support that. ISO versus anti-peristaltic, I know that some of my colleagues still just do what they've always done, which is an anti-peristaltic side-to-side functional end-to-end anastomosis demonstrated down here. One of the challenges with doing it this way is that it can be more difficult to endoscopically evaluate the patient downstream. And since pre-anastomotic ileum is the most common location of recurrent disease, this is a helpful area to be able to see. So isoperistaltic can be helpful for that. Moreover, I know that people in Cleveland still to this day like the end-to-side anastomosis for an ileocolic resection, as demonstrated in image number 2 right here, which can again be very helpful, almost recreating the ileocecal valve and aiding in endoscopic surveillance downstream. End-to-ends can be helpful for this kind of thing, and obviously gaining popularity or gaining traction more widely now is the Kono-S anastomosis for this, which we'll review in a moment. As far as stapled anastomosis, there were old data that suggested it had lower reoperation rates, and that data is out the window now. It's dealer's choice of sewn versus non-sewn. There is risk of firing a stapler with thickened bowel, obviously, and so you want to avoid the disease segment. The Kono-S anastomosis gained popularity since it was described in Japan around 2009. And the S, Tadakono is the senior surgeon who described it, and the S stands for strut or support. So what we do, as opposed to, if this is sort of the bowel and this is the mesentery, typically when we're firing staplers, we aim it so that it's closing the sides of the bowel towards the mesentery. But when we're performing a Kono-S anastomosis instead, we fire our stapler this way so that we close the anti-mesenteric border down to the mesenteric border, perpendicular to how we usually do. Then image A shows the next step is to sew those three staple columns together. And that creates a support strut, was Kono's theory, which prevents these from stricturing downstream. Following the performance of this sutured connection here, longitudinal enterotomies and colotomies are made at the antimesenteric border. Generally speaking, I don't know if many of you have done this often, but generally speaking, the small bowel stretches more, so you want to do about a 7-centimeter long incision on the antimesenteric border of the small bowel side, 8 centimeters on the colon side. And I generally make it right on tinea libera because then I get to say tinea libera and that makes me smile. Following this, I personally do it with stay sutures at the halfway point of each of these, just to pop this open, and then use a running 4-0 absorbable suture on the posterior wall back here, and run it all the way around to the anterior wall. I do this single layered. Some people do it 2-layered. So I generally only do it when I'm open because I don't want to sew that long robotically. I know that one of my friends in Baton Rouge does these robotically, and it still takes him a while to do each one. But you can see in image F here, the finished product is that there's a staple line behind this, and then a wide open, very large side-to-side functional end-to-end anastomosis that more or less looks almost like a Heineke Miculix stricturoplasty from the get-go. Now, this has gained more popularity ever since around 2020 when the Supreme CD study was released out of Italy that showed that endoscopic recurrence rates were lower at 1 year with a Kono-S anastomosis as opposed to a stapled anastomosis. Obviously, there were challenges with that study, controlling for smoking, controlling for biologic agent use, etc. So personally, I generally only use a Kono-S anastomosis when I've got a fellow who wants to do one, or when there's a recurrent disease, especially, and I know I'm going to do it open. But knowing how to do it as the data continue to come out is important. And my endoscopists who have done subsequent studies, endoscopic studies on these patients say it's easy. It's like driving a truck through these anastomoses. So the other point to make is that obviously endoscopic recurrence, important to note, if you look at the data on endoscopic recurrence of Crohn's as opposed to clinical recurrence, even within 1 year, over 50% of patients will have some degree of endoscopic recurrence in the absence of biologic therapy. So this is why we do this the way that we do, is we do our surgery, start the biologics, ideally within 30 days to 3 months, to not to cure the disease, but to slow the progression of the disease so that it's 25% at 10 years instead of 50% at 5 years reoperation rates. As far as the stricturoplasties go, Heineke Miculix is the one you're going to do most commonly. This is for less than 10 centimeter long strictures. It's your classic longitudinal enterotomy with a transverse closure. Generally speaking, I do these again, short segment, single layer with a running 4-0 Maxon 4-0 PDS, whatever does it for me. So if come from each end towards the center. One of the challenges of it is you're generally going to want to go 1 to 2 centimeters onto healthy bowel on either side just to help with pliability. But that means also that the corner where you're throwing your stitch on each side is actually the stiffest, most fibrotic segment. So do be aware of that so carefully. There are no data to support a second layer preventing leak, but it can make you feel a lot better. So don't feel bad doing it either, The Finney stricturoplasty is another one of these classic stricturoplasties. It's a longitudinal incision along the bowel with a basically side-to-side anastomosis that you perform. It says it's technically more difficult. Again, this is not rocket science. You make a big incision, start sewing all the way along the length of this on each side, and then it creates essentially, for all intents and purposes, a giant diverticulum. The upside is you do maintain this mucosa so that long-term the biologic agent should allow for mucosal healing and absorption while opening up the area well. So this can be handy for 10 to 20 centimeter long strictures, though you have to be prepared for a length of time where you are sewing. One of the challenges of this, again, it may be prone to bacterial stasis or bacterial overgrowth, and you will see patients who have bacterial overgrowth related symptoms associated with this. So do be aware of that. The Jabelet stricturoplasty is an internal bypass. All these stricturoplasties were developed for gastric outlet obstruction, obstructive disease due to peptic ulcer disease. And so the Jabelet especially is more of historical significance than anything else. It preserves the defunctionalized segment of bowel, which is nice if it's stuck to everything in the area and you can't get it out, you're worried about the ureter, things like that. Realistically, you will probably just be resecting anything in that area, though, during your practice. Again, of historical importance here, in 1956, when Eisenhower had his surgery for obstruction for Crohn's disease, and Eisenhower had Crohn's, so now you can tell everybody you know about that, along with multiple heart attacks from his constant chain smoking. But when he had his surgery, he was actually on the campaign trail. And some people think that the reason Heaton chose to do a Jabelet internal bypass from his small bowel to his transverse colon was to help him recover faster with less risk of an anastomotic leak. Now, if I'm being honest with you, I suspect there's exactly the same risk of an anastomotic leak with a Jabelet internal bypass as with a resection. But I wasn't in Eisenhower's belly at the time. The guy who subsequently became the Surgeon General of the United States was in his belly, and so who am I to judge? Again, gaining popularity in many of these stricturoplasty type circumstances. Odds are you probably won't do one over the course of your career unless you do a lot of Crohn's surgery, is the Michelossi. The Michelossi stricturoplasty is where you're doing isoperistaltic side-to-side anastomosis, essentially. The original Michelossi was dividing the stricture at its center point, making longitudinal incisions on either side, tapering the ends, and then in a longitudinal fashion, sewing the bowel together on each side. A modified Michelossi is when you divide it at the end of the stricture on one side or the other. And when you do that, you're sewing healthy bowel on one side on top of diseased bowel on the other. You can do this for any length of bowel because you're just cutting the bowel and overlaying it. And in an ideal world, allowing for the mucosal healing on the disease side will allow for continued bowel continuity. Gotta phrase that one better next time. This can be also very helpful when you've got multiple strictures right next to each other because it just knocks out all of the disease while still preserving the intestinal length. Wow, that was it. I was trying to figure out where I had a typo because I knew I had a typo somewhere in here, and it's on this bullet right here. The challenge of the modified Michelossi is that if things go, every anastomosis you make can go to shit. And if things go to shit with a modified Michelossi, you may be sacrificing healthy bowel in that situation because that's what you sewed to the diseased bowel. So do approach that with caution if you are doing it. Back to terminology rules, because we're at a section break, which is nice. Regime is a system of rules, such as a military dictatorship or things like that. Regiment is a unit consisting of at least 2 battalions. A regiment is a regulated course of diet or management. So when you give somebody a bowel regime, then Kim Jong-il or Kim Jong-un is in charge of my intestines. When you use a regiment, that's 2 battalions in my colon, and I don't want that. We give bowel regimens. Terminal ileal Crohn's. Moving forward. How are we doing on time, guys? On the approach here. Thankfully, this section is short. Terminal ileal Crohn's is easy because the answer is usually resection. You can safely do stricturoplasties along the ileocolic, the ileocecal valve, but generally it's not preferred. Generally, you just resect the area. That's the most common location of Crohn's, still accounting for less than 50%, so a plurality, not a majority. Obviously, as opposed to symptoms which are more vague with jejunal ileal Crohn's, this is the classic Crohn's: postprandial pain, especially the dietary changes of loss of fiber products, eventually stopping eating dairy, changing the frequency or volume of food, only eating dinner, which is always an important one. And patients with Crohn's will always tell you, I eat fine, until you actually get into the details of how they eat. So do always do that for your patients. Do them that favor. They may have weight loss. They may have fistulization. Terminal ileal Crohn's, one of the hardest parts is that it can fistulized to everything in the area, and there's a lot of things in the area. It is high value real estate right there. I've seen fistulas to the sigmoid colon most commonly, to the ascending colon, the small bowel, the duodenum. God, duodenal fistulas are stressful, let me tell you. Bladder, ureter, perforation into the psoas muscle with a chronic sinus tract, as well as enterocutaneous fistulas from this disease. And in fact, one of the patients that I had in New Orleans, who you could see which of his six-pack muscle the terminal ileum was fistulizing through. He did such a good job with it. And he skipped leg day, but his abs were something else, let me tell you. Here you can see on these two images, fistulization to a different limb of small bowel here, and fistulization from the TI adjacent to the IC valve. There's fistulization to the ascending colon here, which is more or less creating the disease creating its own internal bypass. Very often, it's not actually the disease segment that's fistulizing here. It's just proximal to the disease segment. There's a perforation that then creates the fistula and decompresses the intestine in this area, which is the patients that you'll see who have severe disease but don't have dilation greater than 3 centimeters on their cross-sectional imaging. This was a patient who had severe fistulization here and then left the hospital and came back 6 months later with kwashiorkor and ascites due to his severe malnutrition with an albumin of 1.2. So again, you want to, in these situations, operatively evaluate the involved organs, figure out what's what, figure out if it's bystander organ or if it is actually diseased and needs to be resected. You can often finger fracture these apart or sharply dissect them. Debate repair versus resection all the time. Most of the time, if it's bystander organ, you can preserve it. In this gentleman here, we actually had to do a double resection, ileocolic with an endoleostomy, and then we did a sigmoidectomy with primary anastomosis, allowed him to heal for 3 months, then did an iliotransverse anastomosis afterwards. He healed up great, better than I did after the resident burned my finger on this case. You can consider either intraoperative decompression or even just doing a diverting ileostomy for a period of time, let them settle down for a while when they're very, very dilated. And this again gets to the point in the guidelines about staged procedures in very ill patients. Other operative considerations include where your anastomosis lies ultimately. Your ileocolic resection, you can do an internal bypass or you can do you can discuss degree of mesenteric resection. I think I've beaten that horse enough. But oftentimes your ileocolic anastomosis is going to lie right next to the duodenum. So do be aware of that. If you need to, you can always interpose tissue between those to try and prevent the future fistulization, because it's not infrequently in the redo cases where you see that ilioduodenal fistula and you see my blood pressure go up. We discussed how anastomosis can be performed per surgeon preference. Something else here. Oh, the last point I like to make is incision choice too. These days, when I do ileocolic resections initially for Crohn's disease, generally speaking, when you're doing the approach for these, you've undoubtedly done medial to lateral dissections, lateral to medial dissections, top down, bottom up, all the things. As often as not with these Crohn's patients, I'll do a bottom up dissection because we preserve the ileocolic plane at that point for a second resection downstream. And then when you take that for the second resection, you preserve the top down, the transverse, when you start at the gastrocolic ligaments and the hepatocolic ligamentous attachments. So do consider these things when you're doing your approach, because somebody will be doing the next operation. Moreover, when you choose your incision for extraction, it's also important. I have moved these days to intracorporeal anastomosis laparoscopically with a fan and steel extraction, because it gets me away from the disease and produces less scar tissue if next time it's a laparotomy and an emergent operation. I am liberal with hyaluronic acid sheets in these patients because, again, the goal is to try and reduce the risk of recurrent surgery or make the next operation easier. Conclusions about this. Number one, oh gosh, my voice is going to crap. Number one, surgery is commonly used for Crohn's. You guys have seen that this year. As much as anything, your gastroenterologists are going to be the gatekeepers for this. So make sure that they know who you are, that every time you do an operation, they know the date of your operation, that you are sending them your operative notes the day you do the operation, and communicating well with them in a multidisciplinary fashion is critical for the care of these complicated patients. Additionally, know your indications for surgery, because a lot of people will say, oh, surgery is last resort, don't do that. You say, well, the patient can't eat, they're obstructing, they've dropped 70 pounds, they probably deserve an operation. Number two, small bowel Crohn's is best managed with resection when the opportunity presents itself, but any number of reasons can make you need to do a stricture plastic, so being aware of how to do that is important. When you have the opportunity for one of these big Crohn's wax during fellowship, make sure you're there. Don't just go do another robotic LAR. Terminal ileitis is generally surgically best managed with resection. Be aware of where you're dropping your anastomosis and how you construct it. And perforations and abscesses may be temporized with drainage, but they are generally not cured with that. There's still a perforation in the setting of Crohn's, and so in all likelihood, odds are they're going to need a resection downstream. But temporizing it with a drainage does allow for minimally invasive surgery down the line. So there is benefit to that. And lastly, medical management is critical. So again, it's good communication with your gastroenterologist, having a plan in place before you do the operation for what you're going to do after the operation. So you can make sure to get, because it takes time to get biologics approved by insurance, get them squared, get the infusion scheduled, etc. And so if you can get that arranged so that it's set up within 14 to 30 days after the operation, great. You've saved steps. Now I'll take questions, I guess. Joyce likes this picture. She's like,
That was a great talk. Thank you so much. There's a question in the chat that I'll get to first, and then maybe I can ask some of my own. First question was more of like a clinical scenario. What would you do? Middle-aged patient, chronic fibrous stenosing small bowel Crohn's disease with upstream dilation. That's similar to the 3 centimeters, the one that would promote failure. Active inflammation is seen on imaging. Treatment naive. Would you jump to surgery first because of the upstream dilation, or would you treat with steroids and or a biologic, thinking that this be more of a mixed stricture? What would be your
that's a
method?
fantastic question. And this is something we see all the time, obviously. As often as not, so the paradigm has shifted in Crohn's care in the last 15 or 20 years. We used to say, throw the kitchen sink at them first. Steroids, hit them with steroids. Do this, do that, do the other. And part of that has to do with the fact that when Remicade was approved in September of 1999, it was prohibitively expensive for most patients. And so the way they would treat is give some Remicade when things got bad, stop it, wait for a while, see when it gets bad again, give it again, stop it, do it again. And the obvious problem with that is Remicade's a monoclonal antibody, so it's detected by the immune system as non-self. And so the consequence of giving a non-self immunogenic molecule repeatedly is vaccination. So we were vaccinating patients against Remicade in the old days. Nowadays, we generally approach more with a top-down approach. If you know a patient's going to need surgery, don't give a biologic and burn that bridge. And more commonly what happens, especially with most gastroenterologists, remember, are not an IBD specialist who spent extra time and exclusively does IBD care. Most of them have a stable of patients who they scope periodically and 4 or 5 Crohn's patients. So a lot of them treat Crohn's how they used to when they were in training. They may not be up on these things. And so by the time the patient gets to you with that same mild inflammatory fibrostenotic mixed stricture, they've gone through 4 biologics already to try and treat it. So in a treatment naive patient like that, generally speaking, I'll first start with an extensive discussion with my gastroenterology colleague. And again, often by the time I've heard from them, they are already on 40 BID of steroids. Remember, the data suggests that there's no benefit to any more than 20 milligram prednisone equivalent of steroids. More than that, the only thing that does is lead to perforation of the duodenum because of the ulcer disease. But generally speaking, in that circumstance, again, and thankfully, my gastroenterologist and I communicate extensively with these patients. The 3 centimeter-ish dilation is usually our indication that, look, we're just going to do an upfront resection, because even if I don't resect, within a few years, we will have burned this bridge and the patient will be sicker when I have to do the resection. We know the resection is coming. Do it up front, start the medications to stretch out the duration between disease. And that's generally my approach in this situation. It's a somewhat more aggressive surgical approach than some people take, but in this specific scenario, I think it is very debatable. And I think neither one is a wrong answer per se. One of the challenges of Crohn's therapy, though, is that unlike other diseases like malignancy, here we have this philosophy of let's wait till they're sicker. The prealbumin and the albumin aren't low enough. Let's wait till they've lost more weight before we do surgery. We don't say it's an early cancer. Let's wait till it's stage 3 so the med oncs can really gouge them for money. You say, let's take it out while it's early. And it's one of those things where it's, if you know surgery is going to happen, don't wait till they're sicker. Do the surgery, then aggressive multimodal therapy. And the other component of the top-down approach to Crohn's care nowadays is combination medical therapy with the immunomodulator class and the biologic class. And the main goal of the immunomodulator class at that point, the azathioprine, the 6-mercaptopurine, your methotrexate, is more to modulate the immune system to prevent the immunogenic response against the biologic therapy and potentiate the effects of the biologics. And in doing that, you can reduce tolerance and allow for prolongation of the individual biologic therapy. Remicade will last 7 years instead of 5 years, which is a big difference when you're talking about a 17-year-old who needs to have a long and healthy life as a productive member of society.
Yeah, that's a great question, or a great question and a great answer. Kind of branching off of that, if you meet somebody who is a little bit deconditioned, you meet them a little bit later in their treatment course, and you can kind of bridge them with another immunomodulator to prehabilitation. Is that something you may consider? You know, you can give them like nutritional optimization, shakes, bring their albumin up, give them TPN so that they can tolerate a bigger whack?
Yes and no is the answer. Again, it depends. There are a lot of social and economic factors that go into that discussion. In my prior role in Louisiana, one of our challenges was that we became very quickly when I was there, my first month at University Medical Center in New Orleans, they hired an IBD specialist the same month. And so she and I grew our practices together, which is why I wound up doing a lot of Crohn's care and doing a lot of Crohn's talks and chairing an IBD conference for 6 years. And thinking to myself, where did I make bad decisions in my life that this came to me? And we saw a lot of advanced Crohn's in the indigent population. And in those situations, those aren't patients who will be able to get TPN. So if you send them out, you're hoping that they can drink some protein shakes every day, but they won't because there's dairy in them that causes peristaltic activity and cramping. So my old partner and I used to often say, sometimes when life serves you a shit sandwich, all you can do is spread the mustard and take a bite. In my current role, all of my patients are by definition insured because I work for the Kaiser system. But even with that, often, depending on their distribution of Crohn's disease, because of the degree of mucosal injury, they are often losing enough protein that no matter how much TPN you dump into them, they will still maintain their severe or moderate protein calorie malnutrition. And that's especially true in the Crohn's colitis population because of the degree of protein-losing colonopathy and the length of mucosal injury, that because the biologic agents bind to protein in the bloodstream, you will have measurable quantities of Remicade in the toilet, but not in the patient's bloodstream. So again, I would say it's a balancing act in these situations. And it's never wrong to try it, but often as not in those patients, when you try it, they come back worse, not better by the time you get there. That said, a couple of years ago, I had a patient. He came in with a perforation in the setting of Crohn's, and one of the general surgeons took him back, did a short segment resection and primary anastomosis. It turned out it was a jejunal cancer due to this underlying long-standing untreated Crohn's disease. So he went through chemotherapy because of node-positive disease, was fine, wound up in my office about a year after everything was done, healed up, but unable to eat and on TPN for the entire year. I said, why the hell is this guy still on TPN? And thankfully, because of the TPN over the course of a year, and again, his specific phenotype of Crohn's was not long segment mucosal disease, it was multifocal short segment disease. So he got the classic Crohn's whack. I think he got 5 stricturoplasties and an ileocolic with a cone OS. But we talk about these patients as if Crohn's is a single illness. And Crohn's is such an umbrella term of different phenotypes, distributions, progressions, that I think you have to take all of these things in conjunction with one another to determine best course of action. And that's where the multidisciplinary discussion comes in. But the short answer to your question is most of the time they're going to get worse, not better.
Right. Setting up a multidisciplinary Crohn's conference seems like a really good idea for Did you end up doing that at UMC, or did you?
I've done it twice now.
Yeah. How much
And
work is that? Just that's a personal question for me. I'm just curious because I might want to do that.
you got to find the people who are passionate, and that's always the starting point. And when I got to UMC, thankfully, my old boss, Guy Ranchio, he's the past president of the society. He was awesome about it. He was very, as soon as I got there, he also believed that that was going to be important. And we got our IBD specialist on board. And we had the fellows from both Tulane and LSU in gastroenterology involved in presenting cases. I started asking around and found the 3 body image radiologists who were really interested in these things. And so I learned a ton of radiology from those 3 guys. I found it was hard to find we had a bit of a rotating GI pathology group, but we got the GI paths into it too. And once you find a few people who are passionate about these things, it takes on a life of its own. And it is so helpful for both the education of trainees and for the multidisciplinary care. And arguably one of the best parts that came out of that multidisciplinary approach to our Crohn's patients at University Med Center in New Orleans was that we would have the conference once a month, know what our plan was for the patients. Our IBD nurse navigator, who was fabulous, would keep track of the patients, know when their operative date was, and on their 2-week post-op visit, they had a visit with the surgeons, and that same afternoon, a visit with gastroenterology. And we sort of said, go ahead and start it, and they have the biologic on board within 2 weeks. And I think it streamlined the care a lot. And if you have but it also, God, it took a lot of work. And when I got here, we've started one again, but the degree of passion is different. And even my level of finding the extra time is hard. We used to, and in Louisiana, it was hard to find time. We started on Thursday mornings, we went to afternoons. I think eventually we settled on lunchtime meeting, and it worked out super well because then I would bring a ridiculously large fried chicken sandwich in and eat, and we would talk about Crohn's and how other people can't eat, and I would feel guilt.
Yeah.
But I think that it pays dividends, that level of work in the early going.
Okay. Yeah. A question from the audience was any time frame for holding biologics before surgery? I think
The data are controversial.
yeah, the Pacini trial is I think recently out, which said there's no real role for that. And what do you think?
Pretty much every trial has shown that, but people still get nervous about it. In fact, just 2 weeks ago, maybe, I did a lap ileocolic in a young woman who was on infliximab, Inflectra, the biosimilar of Remicade. And I got a message from my pre-op clinic being like, well, she just got it 3 weeks before, and she's not, and I was just like, I'm just gonna do the operation. She'll be fine. And if I do it halfway between her Remicade doses, then she never has to miss a dose. But it shouldn't change that, and I'm not going to change the date of my operation for that. And the data seem to fairly consistently show it doesn't matter. With that said, most of us do a lot of this. Number one, often as not, by the time it's time for surgery, they're going to be switching biologics afterwards anyway. So it doesn't make a difference. And number two, the sort of just to make you feel better, when you're in good communication with your gastroenterologist, often what you'll do is just schedule the surgery for the time that they would be due for their next dose when they're at their nadir. Do the operation and restart a couple weeks later. And that just takes good coordination and communication. The honest answer, so when I was in New Orleans, I was my own scheduler too, as well as my boss and my senior partner's schedulers, because nobody else paid attention to their schedules, and the boss would schedule 5 colectomies in a day and be there till 2 a.m. So, we had to protect him from himself. So I was much more aware of it. And depending on your practice pattern, in the role that I serve now in Oregon, I have a surgery scheduler who decides what operations I'm doing on any given day. And I just say, sure, I'll show up and I'll do what I'm there to do. So, I generally don't do, we spitball it, but I wouldn't stop the biologic to do surgery.
Right. And then you continue, when would you restart medical management after resection? That was another question in the chat. And then I think we'll call it because it's getting a little after 8.
The goal is, my goal is within 30 days. If the patient's doing well, just restart. And within 2 weeks, it's perfectly safe. Some of my gastroenterologists here say, yeah, 30 days sounds great. Others shoot for 90 days. The reality is endoscopic evidence of recurrence will be present 70% of the time by 1 year, and ubiquitously so by 3 years. There's a word-for-word quote from the 2020 guidelines that I was double-checking today. And I often have to point out that 25 to 50% of Crohn's patients will have endoscopic, microscopic evidence if you biopsy the anastomosis at 30 days. So basically, it's the sooner the better, but acceptance is the final stage. It's going to come back. And it will take years for that to be clinically evident, even though it is endoscopically or microscopically evident. So the goal is, the reality is, I don't think it matters that much, 30 days versus 3 months. But my prior IBD gastroenterologist was very regimented, not regimed, about 30 days. So that was always my goal.
All right. Well, fantastic. Thank you so much. I really appreciate the time you took to put this together.
Yeah, thank you for the
Nice
invitation.
subject.
Appreciate it.
Yeah.
It's something I always like talking about.